You can put all your questions in the chat or the question and answer section. Sam will be flagging it up to me, and I can stop in the middle and explain it to you. All your questions will be answered. Just put them in the chat. Sam?
Hello, Mr. Hashim.
Yeah, hello. So just keep an eye on the message and on the chat. And if any question, just stop me. Okay?
Yeah, right. Yeah, okay.
We're ready to start.
Okay.
You all can see my screen.
Yeah, it's clear, yeah.
Perfect. Okay, so it's as we're going on the lecture number 5 in our instructional foot and ankle course, and we'll discuss today a very important topic, very commonly to come in the exam, very always missed from clinicians and when you start to read foot and ankle. Hallux rigidus is very common, it's okay, but lesser tooth conditions, neurological conditions of the foot and tendon conditions are always missed. They are always overlooked, and they are very important to understand. Again, my name is Mohammed Hashim. I'm a foot and ankle consultant in Northwest London, Wexham Park Hospital, and this is where I come from. And again, all these educational events will be in my YouTube channel, Hashim's Educational Channel, and also be my official channel. Good. So to start with Hallux rigidus, we need to understand that Hallux rigidus, from the name, is a hallux with limited dorsiflexion. And it's very commonly, the commonest cause of this is arthritis of the first MTB joint. So Hallux rigidus isn't a misnomer. It's actually a proper nomer. So because the main problem of this patient will be difficult dorsiflexion and difficult push off. The main job of your first MTB joint is to help you in the push off stage of the gait. That's why the Hallux rigidus, why we specify as rigidus, because the main problem you will have is that your hallux has a limited dorsiflexion. It couldn't do a proper push off, and this affects your gait, and this gives you the pain. So Hallux rigidus means arthritis of first MTB joint, and we call it rigidus because of the limited range of motion, especially the dorsiflexion range. You need to have at least a 70 degree of dorsiflexion range so you can do a proper push off during the gait. So the patient will come to you with a history of pain. The pain is mainly around the first MTB joint. As you can see, it could be some bony prominence here, which may be missed as a bunion. As you can see, this is not a bunion. This is mainly a dorsal osteophyte. Bunion will be always on the medial side, but this is purely a dorsal osteophyte. The normal daily activities will be affected, especially wearing shoes, especially running, jogging, whatever he needs, the patient needs a push off for, will be limited by the Hallux rigidus. When you start to examine this patient, it's very simply, you can spot from here the dorsal bunion, very prominent, as you can see in this picture. While you seeing the patient from the start, it's not uncommon for this patient from front. It's not uncommon for this patient to be flat, so may have a flat feet. And when you have a flat feet, this adds to the problem of the Hallux rigidus. With flat feet, you need more push off, more dorsiflexion of the hallux to do a push off. That's why with flat feet, the Hallux rigidus problem is more prominent and more symptomatic. When you feel differently, you'll find some tenderness over the first MTB joint, and the most important is to move it to diagnose Hallux rigidus. So you need the normal range of motion of the big toe, which is normally 70 degree dorsiflexion to 25 to 30 degree plantar flexion. If you have this range of motion limited, you have a Hallux rigidus. The main problem will be, as we agreed, the dorsiflexion will be a bit painful, limited, with a difficult push off. To diagnose this more, so the range of motion, you need to specify where is the pain. Is the pain at the extreme range of motion? And this means the main articular surface is still intact. The problem is mainly in the periphery, not in the central articular surface, or your pain is in the mid-range. If the pain is in the mid-range, means the joint has gone completely. So when you start to move your first MTB or moving your great toe, if you move the great toe of the patient and the pain is in the mid-range, this means the joint has completely gone, because this means a central arthritis. But if you move your the grade 2 of the patient and the first MTB is moving, but the pain comes at the extreme dorsal or plantar flexion, this means that the articular surface is worn peripherally and the central articular surface is still intact, and this is a minimal degree, and this is still will benefit from preservation surgery. But the one with mid-range arthritis or mid-range pain, this is the one which will need fusion or replacement. You can do the grain test, and you need to understand the grain test. It's a very painful one, so be careful. Alarm your patient that you're doing a painful maneuver. And basically, you axially compress and start to rotate. It's not this one. No. You basically alarm the patient, have a look in the face, push on the, compress the first MTB joint and start to rotate. So grinding means compression and rotation. The common cause of hallux rigidus is definitely osteoarthritis, the most common cause, about more than 90%. You may have a rheumatoid arthritis or post-traumatic arthritis. So when you classify the hallux rigidus, we can classify it very simply as I explained you. It's just painful joint with no limitation of range of motion, no joint space narrowing or any features on the X-ray. And this is grade 1. This doesn't need anything, just an operative measure, some pain management, maximum and steroid injection. Then mild space narrowing and dorsal osteophyte, which will be represented when you examine the patient by painful extreme range of motion, and this will benefit from chylectomy, means shaving of the dorsal osteophyte. Or grade 3, which you have complete loss of the joint space, the painful mid-range of motion, and this definitely will need either fusion or replacement. So if we decide on a hallux rigidus 1 or 2, and we will start with non-operative treatment, all what we need is to give the patient a wider shoes, try to give the patient a specific splint you see on the right side, which have what we call Morton's extension orthosis or insoles. Morton's extension, this is get the grade 2 out of the way. So it doesn't allow the grade 2 to do a toe off, so there is no dorsiflexion, so there is no pain. And most of the time, this does control the patient's symptoms and give the patient a good relief unless the patient is badly arthritic. So wider and extra depth toolbox. Number 2, Morton's extension insoles or orthosis. Number 3, if the patient is in grade 2, so we have the option to do a chylectomy. So basically, chylectomy, you just open the joint dorsally, and from when you open the joint dorsally, you go and shave about 20% of the articular surface to get the dorsal osteophyte off, and this allows the joint to move freely again and gives it the normal dorsiflexion. The point is if chylectomy needs to be done properly. So it's not just shaving the osteophyte itself. You have to take part of the articular surface, because with the time, when you have a dorsal osteophyte, the proximal phalanx starts to develop another osteophyte, which is what we call the kissing osteophyte. So you have to take a proper bunch from the articular surface, at least 20%, to give you the effect of proper dorsiflexion, and the patient gets to get the benefit. There's another option of Moberg procedure. I have a photo of it. Yeah. So Moberg procedure, basically what you do is you come here, and then you do, as you can see, a dorsal closing wedge osteotomy of the proximal phalanx. So actually you change the axis of the joint. So rather than the normal axis of the joint here, the right axis of the joint will be here. So basically, rather than fusing the joint, you need to get more dorsiflexion. So basically, you do this dorsiflexion by bone osteotomy. So you do a closing wedge dorsal osteotomy of the proximal phalanx, and this is what is called Moberg procedure. Then if both options fail, or the patient already in grade 3, so the option you have to this joint either to arthrodese, replace, or excise. So excision, which is a very old-fashioned operation, it's not done anymore, which is called Killer's arthroplasty, is basically you go take the joint off and just keep the toe floating. So that's why we keep it for the elderly low demand patients, especially if they have rheumatoid and there is no option with the soft tissue. Soft tissue are in a very bad condition. And there is a specific joint degeneration, and what you go and excise the proximal end of the phalanx, but you end by a floating toe. That's why we don't like this operation at all, unless you have no other option. Like the patient have a recurrent infection, recurrent instability, and you feel that putting implant in this patient will be catastrophic. This is when you go for killers, and to be honest, I haven't seen it for the last 4 or 5 years. So killers is a very old-fashioned operation. We do it in very extreme conditions when there is no option to arthrodese or replace. then the actual treatment of hallux rigidus is either to replace the joint or to fuse it. And replacement is getting more and more popular at this time. The problem with the replacement, it starts with the one on the this implant on the right side, which is the Cartiva. And the problem with the Cartiva, it has many generation. Second generation of it has a catastrophic failure, and this what gives MTB arthroplasty the bad repetition it has. But nowadays we have the stylistic implant, and this stylistic implant is doing very well. That's why NICE start to recommend it as an option for treatment in osteoarthritis and rheumatoid arthritis. It wasn't, again, an old repetition that the stylistic implant caused severe synovitis. To be honest, the patient we're doing the new implant at the moment is doing well, and it's a very good and valid option for hallux rigidus treatment. Still, osteolysis can happen. Still, synovitis can happen, yes, but it's not that bad option. So that's why you have to explain your patient the pros and cons of arthroplasty versus fusion. Fusion will end the patient with no movement at the joint. He needs to have the DIB joint to be supple, and it ends by the patient with no option to have a high heel. So it has its own cons. So you have to explain your patient. All days we don't explain the arthroplasty. We get the arthroplasty out of the equation because basically the Cartiva and the old generation of stylistic were bad. Now the new generation of stylistic implant is good, very easy to do, very quick operation, and it is quite successful. That's why NICE start to recommend it, and that's why you need now to explain it to your patient as an option of treatment. Fusion on the other side remains the gold standard. Easy operation, quick one, first operation for any foot and ankle surgeon to do. You need to understand where you want to put your fusion, where you want your grade 2 to be in after fusion. So you need to keep the hallux in about 5 degrees valgus, in about 20 degrees dorsiflexion to clear the ground, and as much as you can in neutral rotation. So the position of fusion of the first MTB is 0 to 5 degree valgus, 20 degrees dorsiflexion, and as much possible neutral rotation. Indication, definitely if the patient become in a lot of pain, it's not controlled by non-operative measures, or the patient already in grade 3 and symptomatic and cannot manage his normal daily activities. This is the time the patient needs fusion or arthroplasty, and you have to explain both options. How we do fusion? Very simply, either you open a medial approach, dorsomedial approach, or dorsal approach. You go inside, you clear the articular surface with special reamers, and then you put your joints together, stick it with a wire, and then if you're happy with the position, you put a compression screw across the joint. Some people do across screws, some people do a screw and plate, and a screw and plate is still the standard. So the standard is to put a cannulated compression screw just to get the articular surface together and stick a neutralization plate on top of it. The evidence says there is no difference, but in what we see in the practice, the plate and screw is the best option. Screw to compress the articular surface, and plate to add to this compression and neutralize all the forces. This patient walks straight away after the operation. You keep him just on a heel weight bearing for 6 weeks, get an X-ray. If the X-ray is okay, then this patient go to normal shoes and has no problem. The only problem the patient has to understand that he will depend mainly on the DIB joint for the movement. That's why if she is a woman, she cannot use a high heel more than an inch, which is very low high heel. Okay, so and the patient need to be aware of this. Patient will have some difficulty walking on uneven surface, going up heels. The patient need to understand this very well. For you to explain to the patient clearly what is the problem be, you understand when you try now yourself. So if intentionally you don't intentionally move your toe, the normal movement of the toe comes from one of two joints, not two of them, only one of them, either MTB or DIB or PIB. And I'm sorry, IB. So when you move your toe, normally try to move your toe now while I'm speaking to you. You will find that your toe move up and down normally without intention, either through the MTB or through the IB joint. And because the MTB is fused, the IB will be moving. So the patient will not lose the function. So the patient, most of the patient understand that, oh, I'll diffuse my first MTB, my function will be affected. No. Because normally, imagine now on your foot that you stop the movement of your MTB joint, you will find that the same movement of the toes is happening from the IB joint. And basically, we fuse this joint, we are sure that the IB joint is supple, so the patient still have the same function he will have from the MTP. So this is, we now already spoken about all the condition of the hallux. So we spoke about hallux varus, valgus, hallux varus, and hallux rigidus, and this is the most common condition of the hallux. We'll shift now to speak about the lesser two conditions. And the lesser two condition, you need to be very careful. They are not that uncommon. They are common, but the good thing is that the patient respond well to the non-operative treatment. And on the other hand, thanks God that the operative treatment of the lesser toes is not the greatest. Patient with lesser toes surgeries is always in problem, is always in pain. Lesser toes fusions are always prone to non-union. That's why, thankfully, lesser toes conditions are responding well to non-operative measures. The commonest you see in the lesser toes is the bunionate or the talar bunion. And as you can see, basically it's a talar bunion because in the old days, in the Greek days, the tailors had to send cross leg. And when they set cross leg, all the pressure goes to these 2 points, which is the fifth metatarsal head. So basically the talar bunion is prominence of the fifth metatarsal head. This prominence can happen because one of three options or one of three causes. Cause number one, that the head itself is big, which is what we call type 1. So the head itself has a deformity. The head is big. That's why it causes a prominent or a talar bunion. Number two, when there is a deviation in the shaft, so the shaft itself is deformed, the relation between the fourth and fifth metatarsal is maintained, but the fifth metatarsal shaft is deformed or deviated, as you can see. And the third type, when there is an increased intermetatarsal angle, or when the fifth metatarsal is more lateral or more valgus compared to the fourth metatarsal. So the types or the causes of bunionate or talar bunion, either deformity of the head itself, or deviation of the shaft, or increase the intermetatarsal angle between the fourth and fifth. As I explained to you, this can happen from external causes like compression of the forefoot by tight shoes, or in the old days for the tailors when they sit cross legs. Or it can happen from intrinsic causes like the patient has already a congenital deformity. Could happen from inflammatory arthropathy, yes. And when we judge about this, you need to understand that the normal force fifth intermetatarsal angle is about 10 degrees. So if the intermetatarsal angle about more than 10 degrees, so the patient will have a bunionate from type 3. And this is the most common one. So when we treat the lesser two condition, you need to understand that as any foot and ankle condition, we start always with non-operative. So try to treat the cause of the patient, give the patient a wide toolbox. Ask the patient not to put any pressure on this in these points. If the patient adapt to sit cross legs, he need to stop that. You can do some padding and give the patient some gel pads. Then, if the problem is in the fifth metatarsal head, which is type 1, the easy is to go, as you can see, and do a condylectomy. So remove a condyle of the fifth metatarsal head. So just correct the deformity of the head. If the patient is type 2, which is just deformity of the shaft, the options you have is either doing a chevromedializing osteotomy, as you can see here. You do a V-cut here, and then you shift the head to the medial side and the shaft to the lateral side, and then you shave this. Then you correct the distal deformity of the metatarsal, which happens in type 2. If type 3 or aggressive or severe type 2, you have the option of doing a scarf osteotomy. That's as a normal scarf, you still do 2 cuts, one distal, one proximal, and then shift the whole distal metatarsal in. And definitely, because it's a more proximal osteotomy, it has a more powerful correction. So more powerful correction because it's more proximal osteotomy, and the correction will correct for you severe type 2 and type 3. There is a distal diphyseal rotational osteotomy. We don't normally practice this. We normally practice either chevron if type 2 or a scarf if type 3. And you still have the option of salvage, or just to excite the metatarsal head. The problem with the bunionate, in whatever the osteotomy you do, especially if it's type 3, when the intermetatarsal angle is big, is recurrence. And the other problem is transfer metatarsalgia, especially in young females. So when you do a severe bunionate for a patient, you need to clearly counsel her. It's mostly a female. It's mostly a hairdresser. Don't ask me why a hairdresser, but this is what happens. I can tell you that most of my patients with bunionate were hairdressers, females hairdressers in the middle age, 30s, 40s. You need to tell her, especially if she has a type 3, which is increased intermetatarsal angle, that this is the recurrence is very high, even if you do a proper scarf. Right, Sam?
Got a question, yeah, just a question for Hallux, according to Hallux Rigidus. So, how does the Moberg procedure will contribute to the management and controls symptoms?
So yeah, basically, if you understand with me, this is the normal joint. Imagine this is, you can see the screen, Hassan.
Yeah.
This is a normal joint. Have a bump up here because of the dorsal osteophyte, limiting this dorsiflexion. As I explained you, up to grade 3, when the joint is completely gone, your problem is not in the pain. Your problem is mainly in the movement. Because there is a dorsal osteophyte here, you cannot dorsiflex. Okay? So what I will do for you, I will do a closing wedge dorsally. So move this up. So your normal position will be already dorsiflexion. So imagine that the original joint, before I do my osteotomy, has 30-degree dorsiflexion and 20-degree plantar. Okay? When I close the wedge up and move the proximal phalanx by about 20 degrees, still the joint is moving 30 up and 20 down. So 30 plus the 20 I've done. So this dorsiflexion for you become a 50 degrees. Again, this is the joint, arthritic in grade 2, have a dorsal osteophyte, which is limiting the dorsiflexion to 30 degree and plantar flexion to 20 degree. What I will do an closing wedge osteotomy here dorsally, base dorsally, so that the proximal phalanx will have this degree of angulation. This become the normal for it now, which is about 20 degree. And the joint is moving 30 up and 20 down as it is before the osteotomy. So you have 50 degree of dorsiflexion because you're as if you understand what I said, you have your 2 off coming from the movement of the distal phalanx. So the distal phalanx will be already on 50 degree, 20 degree from my osteotomy and 30 degree which the joint has before the osteotomy. Is that clear?
Yeah, I think so. Yeah, it's a question from Islam Muhammad. I think so. It's clear now.
Yeah. So joint, dorsal osteophyte, with the osteophyte limited the dorsiflexion, which should be normally 70 to 30 degrees. So move 30 up, 20 down. What I do, dorsal closing wedge, I make this proximal phalanx deformed by 20 degrees up with the 30 degree movement in the joint. So the distal phalanx is dorsiflexing about 50 degrees. 20 from my osteotomy and 30 from the arthritic joint.
Yep. Okay.
Okay.
Thank you.
The second condition you will have from the lesser toes will be the overriding or overlapping fifth toe or crossover toe. And to be honest, we see this a lot in the young kids in just very young age. And only the severe cases which will need something to be done. Other than this, it almost pass unnoticed. It's very commonly to be congenital, so the patient is born with it. So basically what happened, there is either contraction of the extensor digitorum longus, which is pulling the toe up all the time. That's why it found a way to go medially, because the line of pull of the extensor, if you imagine this is the foot, the line of pull of the extensor is not that. It stays there. So it aims for it normally. If it does normally go, it always do extension. If it doesn't normally go, it always do extension and varus. Again, and varus. I'm sorry. The line of pull of the extensor digitorum is not here. The extensor digitorum tendon, the commonest tendon, start here and send 4 branches. So the line of pull of the extensor is here, not there. So if this toe is extended and find the space to go in varus, the line of pull of the extensor digitorum will be extending and varus. That's why with contraction of the extensor digitorum, you always find this toe is overlapping the force or crossing over. The other cause, if extensor digitorum is not contracted, is to lose the plantar structure, like rupture of volar plate, rupture of lateral collateral ligaments. If rupture of volar plate or lateral collateral ligaments, there is no strain here. You have to understand that your toes to maintain in this position, there is the normal arcade of your toes is like that. And it's like that because the tone of the extensors is less than the tone of the flexors. That's why the attitude of the toe is in a bit of flexion. When you have any problem of this balance, either the extensors are taking or overpowering or taking precedence, or the plantar structure are getting weaker, the volar plate and the lateral collaterals, the situation will be is hyperextension as MTB. And as I told you, because the line of ball of the extensor digitorum is not straight, it's coming in varus, the toe will go crossing over. So the balance for your toes to maintain in this position, have a look on your foot at the moment. Your toes will be like that. The lesser toes will be like that. They are like that because the volar plate is intact, dorsal capsule is intact, extensor tendon is intact, flexor tendon is intact, and all balanced. Normally, the flexors are stronger than the extensors. That's why your toe, as you can see, flexors is overpowering. Toe is not like that. Toes are like that. When you have any disturbance of this balance, either the extensors are getting overpowered, and when they taking overpower, they hyperextend here, and because the line of ball is coming from the medial side, the toe go into varus and overlap. The same action will happen if the extensors are normal, but the volar structures get damaged, like the rupture of volar plate or lateral collateral. So there is no more restraint in the plantar surface. That's why MTB will go in hyperextension, and then the toe will go into varus. It can affect the second to overlap the third, or the fifth to overlap the fourth. So if the patient starts to complain, mostly this patient will not complain. But if they start to complain, unfortunately, the only option is to recorrect it by the Butler procedure. And to understand the Butler procedure, have a look on the image on the right side. This is how the toe will be extended and in varus. So what you do, you just do a V cut here, like a racket incision. Then you release the extensor digitorum. You do extensor digitorum tenotomy and a dorsal capsule release. And then what you do, you pull the toe to this side. Then your racket incision will become a Y rather than a V. So you start here, you have a V or racket incision, then you release the extensor digitorum, you release the dorsal capsule, you pull the toe back in place. What will happen? This will make the V into Y, then you close the Y. The problem with this, it does very, very good correction, but the problem is the digital vessels. Because the vessels are adapted to this position for years. When you correct the toe, you do stretch over the medial digital vessels, and it's a very risky on the vascularity of the toe. That's why you have to keep an eye on this toe until it's blinking again, until it's back pink again. So Butler procedure, again, as any VY anywhere. You do a V incision, or racket incision, release extensor digitorum, release the dorsal capsule, pull the toe back in place. This will create from the V a Y shape. Then you close the Y shape, as you can see here. You have to warn your patient, you have to be careful about the digital vessels, because you stretch the digital vessels on the medial side, and there's a risk of this toe to become ischemic. Then the curly toe, and the curly toe is is basically, rather than overlapping, is underlapping, commonly to happen at the third or fourth toe, and we see it very, very commonly in the very young children. As you can see, these feet underneath. All of these patients doesn't complain, and if they start to complain, we just do a tenotomy by a needle. So we needle tenotomy the tendon here. This will release the toe, and the toe will be back in a normal position. So rather than overlapping, as we agreed before, the curly toe is underlapping. So because it's underlapping, again, it's more powerful flexion than extension. And if the patient starts to complain, easily go here and do a tenotomy of the flexor tendon, and the toe will be correcting. So then you come to the common deformities which happen in the lesser toes in combination or as a result of the hallux valgus especially, or the flat foot especially. And I need you to concentrate a lot on this picture. You need to understand the difference between the three. So mallet toe, exactly like the mallet finger. What happened? You lost the power of the extensor digitorum longus. Either the tendon ruptured, either the disavulsion of the bone, whatever the cause. So all what you have is flexion of the distal phalanx only. So mallet toe is exactly as the mallet finger. You have the mallet finger when the extensor digitorum longus ruptured or avulsed. So you have a flexion of the DIB only, flexion of the distal phalanx only. If the flexion of the distal phalanx is associated with hyperextension in the MTB joint, flexion of the hyperextension in the MTB joint, flexion in the BIB joint, and extension in the DIB, which resemble what's called boutonniere deformity, this is what we call the hammer toe. So your hammer toe is flexion at the BIB, not in the DIB, with extension at the DIB. And I will explain you clinically, mechanically how this happens. Claw toe basically is hyperflexion. So you have flexion over BIB and DIB. Again, mallet means loss of the long extensor digitorum, either by avulsion or rupture or whatever the cause. So it has a flexion at the DIB only. Claw toe is flexion at the DIB and BIB, and this is occur when there is overflexion power, and I will explain you why again now. And hammer toe is the other way around, when there is a flexion in the BIB but hyperextension in the DIB. Okay, so to explain you, basically, this is very simple. Mallet toe, the extensor digitorum long is ruptured, avulsed, whatever. There is no more extension power in the distal phalanx, so that the flexor tendon, the long flexor tendon takes over powers. So flexes this distal phalanx. With the claw toe, this is commonly to happen with the neurological conditions. And as we agreed from a minute ago, that flexors are normally overpowering the extensors. So when the patient have a neurological conditions which is causing muscle contraction or muscle overpower, the flexor will still overpower the extensor, so it will flex the BIB and the DIB, and as a result, the MTB will be extended. Remember from the first lecture, MTB is moved by intrinsics, while BIB and DIB are moved by the long flexors. Because the MTB is not moved by the long flexors or long extensors, by the long tendons, it's just by intrinsic muscles. That's why it moves just as a compensation for what happens in the DIB and BIB. So when the patient have a neurological condition, there is overpower of the flexors, which is normally overpowering the extensors, and this ends by the flexors flexing the BIB and DIB, and as a reflection, that MTB joint will be extended. This is how the claw toe happens. Come to the hammer toe. The hammer toe, the commonest cause of it is attenuation of the plantar plate. When you have an attenuation of the plantar plate, so there is nothing restraining the MTB in place. So what happens? The MTB go into dorsiflexion. And because the MTB is extending, normally the flexor tendons will flex the BIB joint. The problem with the difference in DIB is because the intrinsics here are not functioning well, so it's always under contraction of the flexors, and that's why the DIB joint is extended. Again, mallet toe as a mallet finger. All what you lost is the long extensors, so the long flexors will be overpowering and flexing the DIB and the distal phalanx only. Claw toe happen with neurological conditions. When the patient has neurological problem, which is causing muscle contraction or overpower, and because normally the flexors are overpowering the extensors, the toe will be flexed at BIB and DIB joint, and as a compensation, MTB will be extended. This is totally different than the hammer toe, when the problem mainly in the MTB. Plantar plate attenuation, so there is no more restraint plantarly, so the intrinsics will pull the MTB joint dorsally and causing the extensor mechanism to be into action. And flexor tendon will pull the BIB in flexion, while the intrinsics, because of the extension, the extensor band or extensor mechanism, the DIB will be in extension. Plantar plate attenuation, this is the most important. This is where this is very simple. For again, the hammer toe, the problem starts in the plantar plate attenuation, intrinsics, because there is no more restraint here. Intrinsics will be pulling the proximal phalanx into extension, and at the same time they put the extensor mechanism into action. That's why the DIB joint will be extended. Flexor tendon, because the MTB has extended, the flexor tendon will be shortened, so it will pull on the BIB and causing BIB flexion, and this is how this boutonniere deformity or hammer toe happens. Flexion at the BIB and extension at the DIB. Hussam, is this clear?
Yes, I think so, yeah.
Okay, so how we treat this? What's the problem with this patient? The problem with the mallet toe will be hitting the ground by the distal phalanx. The problem with the claw toe, that this part of the toe will be rubbing against the shoes, and patient will be unhappy. And same for the hammer toe. The main problem is callosity here and rubbing against the shoes at the BIB joint. So if the patient is still early, especially with the mallet toe, what we will do, just a mallet splint, as you normally do with a mallet finger. So you bought a mallet splint, which keep the DIB in extension, so give a chance for the tendon to heal or for the avulsion fracture to heal or to unite. If the patient is still flexible here or there, the main problem is it's not in the flexor, but the flexor is the main powering, deforming force. So what we will do, just percutaneous FDL tenotomy. When you release the FDL here, there is no more extension, so this will release the power. If the patient become in a fixed deformity or dislocated, so the option we have is to do what's called Stensby procedure. So we excise the distal part of the proximal the proximal part of the proximal phalanx just to shorten the toe. We release the extensors and bolt the extensors into the plantar plate, so maintain the toe floating but balance it. Mallet toe, early will both just a splint, and the splint will maintain the DIB in extension until the tendon heals or the avulsion fracture unites. Claw toe, what we will do, we go and we release the flexor digitorum longus, and this is will release the whole claw toe because the main deforming force is the flexor digitorum. Hammer toe, what we will do is early we'll release just the flexor, the extensor digitorum longus. If late, what we will do, either we do BIB or BIB arthrodesis, or we just splint, or we just do a Stensby procedure, excise this proximal part of the proximal phalanx, release the extensor tendon and attach to the plantar plate, so the toe will be balanced from up and down, shortened because of the excision of the proximal phalanx, and this will get the hammer toe back to normal. When we speak about the hammer toe specifically, we nearly done everything. It's the most common lesser toe deformity, commonly happens as a result of attenuation of the plantar plate, and this is commonly happens with flat foot and valgus, hallux valgus. The problem, as we agreed, callosity at the BIB joint because rubbing against the shoes. You have to check if the patient is correctable or not, or to do a specific test like the Lachman test in the knee. So you just do a Lachman test, you hold the metatarsal in one hand, hold the proximal phalanx in one hand, and do a Lachman test to ensure if the joint is stable or not. If the joint is still stable, we still have a chance with stenotomy and release. If the patient is not stable, we don't have an option except Stensby. Definitely, we start with some non-operative treatment, give the patient some padding, white 2 box, extra dips box. And if the patient doesn't respond, the option we have either release if still flexible, plantar plate repair, especially if the patient is young and it's not rheumatoid. And if nothing of this helps, so we go for either a Weil's osteotomy or a Stensby. To explain you how we do the Weil's, so basically, your problem with the hammer toe is if it become inflexible, your problem is this is already, the MTB joint is already dislocated. So you see the proximal phalanx is very high up. Okay, and all what you need is to bolt this down. You bolt this down by 1 or 2 procedure. Either you shorten the phalanx or you shorten the metatarsal. How you shorten the metatarsal? By Weil's osteotomy. So basically what you do, you cut here, and when you cut here, you slide the head back. So you shorten the metatarsal, so you shorten the whole toe, so you give a chance for all this to become back in place. You stick a wire in, so your toe will be back in place. The other option, especially if the patient rheumatoid or if the patient is old age or the bone quality is not the greatest for osteotomy, is to go, as you can see in this picture, cut this part of the proximal phalanx, the most proximal part of the proximal phalanx, release the extensor tendon, pull the extensor tendon into the volar plate or the flexor tendon, and just stick a wire in, so the toe will be shortened and straight. Again, we agree the hammer toe, sorry. Okay, we agree that the hammer toe, if it's still very early, we can do non-operative treatment, white 2 box, extra depth box, silicone pad cover, whatever you want. If the toe is not flexible anymore, the options we have, either we have to get this toe short. To make it short, either we shorten the metatarsal or shorten the proximal phalanx. Shortening the metatarsal will be with Weil's osteotomy, and Weil's osteotomy, basically we do a cut here. We go from the upper third of the articular surface and we go parallel to the ground. And because we parallel to the ground, we can slide the metatarsal head back and shorten the toe, and this will will defunction all these muscles. So the toe can come back straight and we stick a wire in. If the patient is very old, we risky to both osteotomy. There is a risk of non-union. You cannot depend on that. So the option you have is to shorten it from the proximal phalanx. Cut the proximal part of the proximal third of the proximal phalanx. Release the extensor tendon, pull the extensor tendon and attach it to the flexor tendon or the plantar plate. This will shorten the toe, make it straight, stick a wire in, and this will end by a floating toe. To be honest, not the greatest operation, again, as the killers arthroplasty in the hallux, because it ends by floating toe, nothing to hold the toe in. Once you remove your wire, the toe is floating, and the patient doesn't like it. Vials is much better option, but the problem with vials, you have to have a good quality of bone for the vials to heal. Otherwise, the patient will be in a problem. When we speak about the closed toe, we agree that closed toe, the problem is mostly neurological. Once you see a closed toe, you have to think about neurology, especially if this closed toe is associated with cavus. Closed toe and cavus equal neurology until proven otherwise. This patient has to see a neurologist before you touch him or her. Patient will come mainly because this is neurology. There is a lot of muscle action. The muscle will be exhausted. The patient will come with whole forefoot pain and definitely overwrapping of the flexed BIB against the shoes. The problem of this patient, as we agreed, is the overpower of the flexor tendons over the extensors, and this is aggravated by the neuromuscular condition. It may happen again, as we agreed, because of the rheumatoid arthritis and attenuation of the soft tissue. Happen with the cavus foot, and we explained this already in the cavus foot. Definitely, if you have a previous compartment syndrome and already the flexors are contracted, gives you the same problem. So the commonest is to be neuromuscular and contraction or overaction of the flexor muscles. Could be rheumatoid, could be a cavus foot, which again a neurological condition, could be a previous compartment of the flexors and contraction of the flexors, which give you the picture of closed toes. If the closed toe is still flexible, so means still the muscles just imbalanced, and this is the time you can do a tenotomy, flexor tenotomy, and release the tendons and get the toe straight again. Or if it becomes fixed, this means the joint has been damaged because mostly it's a long standing. And this is when you have the option of doing a stance B again. Either shorten the proximal phalanx, pull it back, release the tendon, and stick a wire in. So closed toe is neurological until proven otherwise. This is the most important message about the closed toes. Now we'll go to the neurological condition of the foot. They are always overlooked again. If you go back and compare how many cases have you seen in your practice with a tarsal tunnel compared to a carpal tunnel, you will definitely spot that the tarsal tunnel is very underlocked and the carpal tunnel is very overlocked. So I can argue how many cases you have seen of tarsal tunnel, and I'm sure it's not a lot. So as we do with the carpal tunnel, you need to understand the anatomy of the tarsal tunnel. Tarsal tunnel is just behind your medial malleolus, and it's triangular in shape. The anterior for it is the medial malleolus. The lateral for it is the talus and calcaneum, and the cover of it or the top of it is the flexor retinaculum. It has inside the tip post, flexor digitorum, artery vein nerve, and flexor hallucis. Tip post, FDL, artery vein nerve, and FHL. What the patient will come to complain with, he will mainly complaining from pain, mainly in the medial side. As you can see, the main compression will be over the tibial nerve, and the most affected is the medial plantar nerve. Patient will come with medial foot, and it's always vague pain, maybe having neurological symptoms like burning, paresthesia, and this definitely works with exercise because the muscles, if you have seen before, so the FHL and FDL, especially the FHL, is muscular till a very low level, and with exercise the FHL gets bigger, and this is make more compression inside the tarsal tunnel, and that's why the symptoms gets worse with exercise. When you examine exactly at the carpal tunnel, if you put your hand over the tarsal tunnel, the symptoms will be aggravated, the paresthesia and pain will be aggravated. You can do a Tinel sign, you can do a Fallin test, same as you do for a carpal tunnel. The commonest to cause a problem in the tarsal tunnel is either intrinsic or extrinsic. So intrinsic, like a tendon sheath ganglion, a tenosynovitis, lipoma, exostosis, anything which comes intrinsically from inside the tunnel. What comes from inside the tunnel? Tendon ganglion from a tendon sheath, tenosynovitis and inflammation and swelling of the tendon sheath, lipoma, or exostosis or osteophyte. All these are intrinsics to the tunnel. Other than this, it may be an extrinsic, which like an post-op scarring if you're operating at this area. And this is definitely very worse prognosis because even releasing the tunnel will not solve the problem because the compression comes from outside the tunnel, not from inside the tunnel. Remember, and this is a technical tip you will not hear in anywhere, the tarsal tunnel is always you always miss a proximal injury. A proximal lesion. So when you have a tarsal tunnel, don't be distracted by the tarsal tunnel only. Always do a full scan for the patient starting from the knee. It's very, very common to miss a proximal lesion or a proximal entrapment or proximal compression, and you just concentrating on a tarsal tunnel. From my experience, tarsal tunnel in itself as an intrinsic is not that common. The common is the symptom, and the symptom when it is there is not only the tarsal tunnel, but it's more commoner to have a proximal lesion. Okay?
Yes, just a question from Ahmad Chalen. What's the rule of the tendon transfer in standby procedure?
So Ahmed, if you have a lock in the stents, we didn't do a tendon transfer. But basically, if you release the extensor and remember, you are not at the time of putting the wire. When you get the wire off, and the extensors are already tenotomatized, so the flexor is only working. What will happen? This toe will flex. You need to have the tendons working when the toe balanced. So you did tenotomy of the extensor, and the flexor is still intact. Once you remove your wire, the flexor will be pulling the toe down, and this will make the toe rubbing against the ground. What you want to do is to maintain the tendons acting on this toe balanced. That's why the tenomatized extensor tendon is reattached to the flexor. So when the flexor go into action after you release your wire, it will be extending and flexing at the same power, so that the toe will be balanced. You cut proximal phalanx, you get the extensor tendon tenomatized. Once you do a tenotomy of the extensor tendon, the flexor is still intact. The flexor is still intact. You put your wire, the toe will be straight. Once you remove your wire, because you did a tenotomy of extensor without the flexor will be pulling the toe down. Especially remember, the toe is floating. There is no MTP joint anymore. When it pull it down, the problem of the patient will be more because this toe will be rubbing against the ground. To avoid this, you just get the distal part of the extensor tendon, which you did tenotomy, attach it to the plantar plate or the flexor tendon, and because it's attached there, it doesn't allow the tendon to flex. So even if the tendon try to flex the toe, the extensor which is attached to the tendon itself or the plantar plate will maintain the toe balanced. And this is end by the toe floating, yes, but floating straight, not flexed, not extended. I hope this is clear. It's not a transfer. All what we do is just get the extensor tendon, which is tenomatized, back to the flexor tendon or the plantar plate, not to allow the flexor tendon later on after we remove the wire to bolt the toe down or to bolt the toe into plantar position, because the patient problem will be more in this condition, because when the flexor tendon plantarized the toe will be rubbing against the ground, and the patient symptoms will be much, much worse. So all what we do is just attach the extensor, which is already had a tenotomy, to the flexor to maintain the toe straight. Okay. If you tarsal tunnel investigation, same as any entrapment syndrome. So any nerve entrapment syndrome, any other where in the body, what you do a nerve conduction AMG, and you do MRI scan to detect any local compression cause. So AMG will be waiting in early stage just for a delayed speed and an increased latency, and later on, if the nerve start to be degenerating, the amplitude of the nerve waves will be low. So early stage is just delayed transmission, which is the nerve is still in neuropraxia, so will be a decreased speed and a prolonged latency. at later stage, when the compression is long standing and the nerve start to degenerate, will be decreasing the amplitude of the nerve waves. MRI scan will spot to you what is compressing the nerve inside. So we'll show you if there is a ganglion, if there is a lipoma, if there is an exostosis, whatever. And the treatment, definitely non-operative treatment if the patient is an early stage. If the patient starts to have motor weakness, especially in the adduction of the hallux, so you have to go and surgically release it. Remember, surgical release is very successful if you're sure that the lesion is in the tarsal tunnel. Don't forget to check if there is a proximal lesion or not. When you ask for an MRI scan, don't ask for MRI scan of the hind foot. Ask for MRI scan of the whole leg, because it's not uncommon to have a proximal entrapment or compression, and the symptoms are tarsal tunnel syndrome symptoms. So, and if you release a tarsal tunnel with missing a proximal lesion, patient will not get any benefit. So remember, proximal compression or entrapment is not uncommon with tarsal tunnel. So always check the nerve proximally before you commit to release the tarsal tunnel. If there is no proximal lesion and you really release, and it's an actual tarsal tunnel syndrome, if you release the tarsal tunnel, patient will get benefit in 85%. The other tunnel we have, because the tendon, the foot has 3 retinaculum, so 3 compartments, posterior, anterior, and lateral. So there is flexor, extensor, and peroneal retinaculums. The other tunnel we have is the anterior tarsal tunnel syndrome, and this will be compressing the deep peroneal nerve. And again, the anterior tarsal tunnel is a space under the superior extensor retinaculum. As we all agree, behind will be the distal tibia, cover will be the extensor, superior extensor retinaculum. What moves in is tibialis anterior, then AHL, then nerve artery vein, then artery nerve vein, then the EDL, then the peroneus tertius. It's about 1 centimeter proximal to your ankle. And the causes, again, same as tarsal tunnel, either something coming from inside the tunnel, like a ganglion, like an osteophyte, like a tumor, like a tenosynovitis, same story, or extensor extrinsic impingement, and mostly either patient using high heel, and because patient is using the high heel, the patient is putting the extensor retinaculum into very stretched position, and it's compressing over the nerve. The other one is to have a very tight laces or ski boots, and if the patient has a trauma to this site, especially if the patient has a recurrent instability of the ankle. Most of the anterior tarsal tunnel are treated conservatively because most of the causes are extrinsic rather than the tarsal tunnel. So all what you need is just show modification, ask the patient to stop the activities which is causing the anterior tarsal tunnel. And if there is no improvement with the conservative treatment, you can go and release the extensor retinaculum or remove the osteophyte or treat whatever the cause which is compressing the deep peroneal nerve. Mortals neuroma, the most common complaint the patient come to foot and ankle clinic with. Very, very common. And unfortunately, it is a misnomer. It's not a neuroma. Basically, Morton's is not a neuroma. It's a synovial thickening. And to understand the Morton's, your digital nerve, you have to understand where is the digital nerve running. Yeah, if you see the digital nerve here, so tibial nerve ended by a calcaneal branch, medial plantar, which is the major branch, and lateral plantar. Medial plantar play the role of the medial nerve in the hand, so supply the medial 3.5 toes. Every digital nerve, as you can see, comes to this place and spread into two small digital branches, one for every side of the toe. The point is, this digital nerve come underneath the transverse metatarsal ligament. And when you have any cause of forefoot overloading, you're basically compressing the nerve against the ligament. And that's why the nerve starts to have a synovial thickening, and this is what we call Morton's neuroma. Again, tibial nerve coming from the back, have 3 branches, calcaneal branch, medial plantar branch is the biggest one, lateral plantar. Medial plantar goes up to the web space and start to divide into 2 digital branches going to either side of the toes. The problem is the digital nerve goes underneath the transverse metatarsal ligament. So it is between the transverse metatarsal ligament and the plantar surface. So when you have any cause of overloading the forefoot, flat foot, using high heels, Achilles contracture or gastro contracture. So if you overloading your forefoot, you with every step you compressing the nerve between the transverse metatarsal ligament and the ground, and this end by the nerve synovial sheath to thicken, and this synovial thickening around the nerve, what's called Morton's neuroma by mistake. So the cause of calling it neuroma is to give the same symptoms. Patient will have a pain and very characteristic pain. The patient will tell you that I feel like it's a foreign body under my foot. When you hear the complaint of foreign body under my foot, remembers Morton's neuroma. Then the pain will be burning type or shotting type. It's a nerve type pain. It goes between the toes and it may be associated with some tingling and numbness, and always aggravated by anything which causes forefoot overloading, because this is how the neuroma happens, or how the synovial thickening, which we call Morton's neuroma, happens. When you examine, you have firstly to examine for the cause. So have a look on the foot, ensure there is no flat foot, there is no hallux valgus, because if you have any of this, you need to warn your patient that whatever you do for the neuroma, risk of recurrence of neuroma is high, because we haven't treated the cause, which is forefoot overloading. When you put your hand, there will be tenderness in the web space. The commonest is the third web space. The second common is the second web space. So it's commonly to happen in the third and second, and very rare to happen in the first. When it happens in second or third, it will be tender over the web space. And when you compress the toes together, so when you compress the toes, you're just squeezing the web space, and when you squeeze the web space, the neuroma will pop up or down, so you will hear what's called Mulder's click. And the Mulder's click will be a sound of click, and the patient will be complaining of pain. And this happens when you squeeze the forefoot. With squeezing the forefoot, you don't leave a space for the neuroma in the web space, because you tighten the web space, neuroma will skip up or down, and then the patient will feel pain, and you will hear Mulder's click. Anatomy, as we explained, differential diagnosis, any problem in the forefoot, MTB, joint synovitis, elongated second toe, any problem, plantar wart, metatarsal head, avascular necrosis, stress fracture. So don't take it simply. Patient come to you complaining of forefoot pain under the second metatarsal head, it's just Morton's. No. Morton's will be specifically, patient will be coming with sensation of foreign body under the foot, tenderness in the second or third web space, wherever the neuroma is, and positive Mulder's click. And still, it is a suspicious, not a diagnosis. So don't take it simply. Always search for other major causes. All the other causes, all the differentials are risky. Morton's neuroma is just a pain. It's nothing risky. But if the patient have a stress fracture, have an AVN of metatarsal head, have any other cause, you have to exclude other causes, or you have to have a diagnosis of Morton's by ultrasound or MRI scan before you just relax your mind and say it's a Morton's. Investigation, the commonest investigation is ultrasound. We send the patient for ultrasound to do assessment, and we ask them, if you find a neuroma, please inject it with steroids. Injection with steroids play two rules. The rule number one is diagnostic. So if the patient pain improves, this means definitely it is a neuroma. So ultrasound assessment, if you find a neuroma, inject it with steroids. If the patient improves, this is definitely a neuroma. If the patient, if the ultrasound couldn't see it, and all the clinical symptoms are coinciding with Morton's neuroma, patient will need an MRI scan. Treatment, conservative treatment is perfect in treating the Morton's neuroma. Most of the patients respond to conservative treatment if they don't have a very clear cause of overloading the forefoot. So our non-operative treatment will be in the form of white toolbox. Ask the patient not to do any exercise or something which cause the patient to overload the forefoot. If patient is not responding, the next step will be ultrasound guided injection in the neuroma, and you can repeat this twice or even 3 times. And patients do respond very, very, very well to ultrasound guided injection of neuromas. If there is no option and you repeated the ultrasound guided injection many times, patient is still complaining, so the option you have is to excise it. And to excise it surgically, you have to go from the dorsal surface. We avoid the plantar surface because the plantar skin is very bad to heal. So we avoid any plantar wound. we go dorsally between in the web space, either second or third, whatever the web space in the neuroma in. You go, you put a laminar spreader, you divide the ligament, because as we agreed, the nerve comes underneath the transmetatarsal ligament. You just divide the ligament, you will see the neuroma. When you push from the plantar surface, neuroma will come into place. You have to dissect around the neuroma proximally and distally, and try to cut the nerve as far proximal as you can, just to allow the nerve under tension, especially to allow the nerve to pull back into the muscle, so you don't have a stump neuroma later on. So again, dorsal incision over the web space, laminar spreader to open the two metatarsal, to get the metatarsal head away, and put the ligament under tension, divide the ligament, the neuroma will pop up. Once the neuroma pops, if it doesn't push it from the plantar surface, it will pop in front of you. Dissect proximally as much as you can, dissect distally to see the two digital nerves, and then I can send you pictures of that. And when you cut, bone the neuroma, get the nerve under tension, and cut very, very proximal as much as you can. So once you cut proximally under tension, nerve will retract inside the muscles. And once the nerve retracts inside the muscle, it will be safe from getting a stump neuroma. If you leave the nerve long, patient will come again with the same symptoms, and it is not a Morton's neuroma recurrence. It is a stump neuroma. It's an iatrogenic Morton's neuroma you caused because you cut the nerve very distal. So the tricky point here is to cut the nerve as far proximal as you can and under tension to allow the nerve to retract and embed inside the muscle, so there is no stump neuroma. And then you dissect the two digital nerve. Warn your patient that the patient will be numb in this area for a good 3 to 6 months until the other digital nerve from both sides start to cover this area. Most of these patients regain the sensation as normal, and if not, very small batch of numb or tingly area, which is not a problem for the patient. Last neurological condition is the foot drop, and foot drop basically because of the problem with tip ant is, as you know, any neurological cause which will make the tip ant weak will cause a foot drop, starting from the brain up to all the neuroaxial, the neuroaxis problems, stroke, head injury, peripheral nerve injury, spinal cord injury, lumbar radiculopathy, compression in the back, Charcot-Marie-Tooth, whatever the neurological cause will end by the foot dropped. And once the foot dropped, you know that the problem is with the tibialis anterior not working. Your main problem will be the gait. You will walk with high steepage gait when you flex the knee and hip to declare the foot from the ground. And our management to this started with just an orthosis to keep the foot up, physiotherapy, and definitely if there is no response, the option we have is to transfer the tendon. And transferring the tendon should be within 3 to 6 months. More than this, the option you have will be is to fuse the hind foot and keep the foot in a plantigrade position, so to allow the patient to walk normally. Last of this lecture, not to take very long, is the tendon problems. And the tendon problems, I'll be concentrating on the most important. First of them is the peroneal tendon subluxation. It's again one of the underlocked conditions of the foot. Patient come to complain from a pain behind the lateral malleolus after a sudden forcible eversion. And the main problem with the patient, while he is walking, he feel clicking, he feel instability, he feel like the foot will invert, and he feel like a bob, especially with dorsiflexion. This what happened, the dislocation or subluxation of the peroneal tendon. It's either the peroneal tendon subluxing from the groove in the lateral malleolus, or there is sometime, and this is a more difficult, if the tendons are dislocating inside the sheath, when the tendons are changing their position. So there is an in situ dislocation between the peroneus longus and brevis inside the peroneal sheath, or the easy and the frank one is the peroneal tendon subluxation from the groove behind the lateral malleolus. The problem of this patient, because the tendons are not in their normal groove, the power of there is no lever. So the lateral malleolus for these tendons act as a fulcrum. And if there is no fulcrum, the tendons will be weak, there will be weak eversion. So the problem of this patient will be weak eversion and more prone in inversion. We all know the anatomy. All I need you know to spot from the anatomy is that the peroneus is this picture. And if you can see here, the peroneus longus is just engulfing the peroneus brevis. Peroneus brevis is more anterior and more lateral, and peroneus longus is more medial and more posterior. So basically peroneus brevis is close to the bone and is more you can differentiate them when you open the sheath. Is the peroneus brevis is more fleshy to a distal end, while the peroneus longus is more tendinous. When you open here, the fleshy one will be the peroneus brevis, the tendinous one will be the peroneus longus. Both supplied by the superficial peroneal nerve, both are maintained in place by peroneal retinaculum superior and inferior peroneal retinaculum, and both of them pass just over the peroneal tubercle of the calcaneum before they go to their insertion. The peroneus brevis inserted in the base of fifth, and peroneus longus insert there in the base of first metatarsal and the medial cuneiform. With the subluxation, patient will come to you complaining of instability, clicking, feeling of weak eversion, and the diagnosis is with MRI scan. Sometimes it's very difficult to diagnose, especially if the subluxation or dislocation happen inside the sheath, and the only option is to diagnose this is ultrasound. Treatment, if the patient is just in early stage, is just maintain the patient in a boat or cast, and this definitely doesn't help a lot. The surgical option is to go and repair the retinaculum if it is repairable, and if it's not repairable, is to deepen the groove, the perineal groove, just to make them more deeper in the bone, and then you can replace this with a tenodesis. Just get the plantaris to reconstruct to do the job of the perineal retinaculum. If you end by no option, so the option is to make them into one tendon. So basically, get attached tenodesis the longest to the brevis, because the brevis action is more important if you have no option to reconstruct or repair the retinaculum. Retrocalcaneal, this is the other tendon which has symptoms and problems with the foot, is the tendon Achilles. And retrocalcaneal bursitis is basically, as we explained in the first lecture, is the inflammation of the bursa between the Achilles and the calcaneum. So Achilles bone, calcaneum, there is hair at bursa, which we call the retrocalcaneal bursa between the calcaneum and the Achilles. This retrocalcaneal bursa on the long standing may be a Haglund deformity, which is bony prominence of the posterior superior tuberosity of the calcaneum. Or what you need to do for a patient with retrocalcaneal bursitis, just keep the patient as much relaxed as possible. Patient have a well padding in the shoes or whatever he bought, and send the patient for ultrasound. If they find that bursitis, they can inject it with steroids. Patient need to do stretch exercises for the Achilles, and definitely in the later stage, if the patient starts to complain, you have to go remove the bursa and the Haglund. When we speak about the Achilles tendinopathy, you need to understand that Achilles tendinopathy, the patient will come to explain you pain in the Achilles on resisted plantar flexion. Especially if the patient starts to stand tiptoe or something like that, or the patient profession like a dancer or something needs the patient to stand on tiptoe, the patient will be complaining of pain on resisted plantar flexion. As I need you to understand this anatomy very, very importantly. So as you can see, the Achilles is formed by the triceps suri, which, as we agreed before, it is triceps because gastrocnemius has medial and lateral head, and the soleus. So medial head of gastrocnemius, lateral head of gastrocnemius, and soleus. Up in the leg, the soleus moves anterior to the gastrocnemius, and when they become distally, they move 90 degrees, as you can see here. And the anterior, which is the soleus, become medial, and the posterior, which is the gastrocnemius, become lateral. So this area of the tendon rotates 90 degrees from anterior and posterior to a medial and lateral. So normally the soleus is anterior to the gastrocnemius in the proximal leg. When you come to the insertion, because of 90 degrees turn, this area of turn, the soleus become medial and the gastrocnemius become lateral because of 90 degrees turn. This has a lot of implications, a lot of effect. This turn in the tendons, why God gives us this turn in the tendon? Basically, this allows the tendon to elongate, and at the same time allow the tendon to release any stored energy if he needs. So if the tendon needs to elongate, basically, because it has this turn, if you go and stretch the tendon more than enough, this turn will correct, and this gives the tendon more length. And at the same time, allow the tendon to store energy until it needs it. The problem of this is the benefit. The problem of this is it's a watershed area. Because of this turn, this area has the least blood supply, and this is the commonest area to rupture with injury. And this is a common area to have a tendinopathy or pathological tendon. Achilles tendinopathy is either insertional at the site of insertion of the Achilles in the calcaneum or non-insertional. And the mechanism, pathological mechanism behind that the tendon has, if the tendon is a lot of action, tendon will have micro trauma, and with the repetitive trauma will have a micro tear, and micro tears will end by a degeneration. So overaction, repetitive trauma, micro tears, and micro tears will be degeneration. Commonly to happen 2 to 6 centimeter above the calcaneal insertion where the turn happens, which is the watershed hypovascular area. How we treat the Achilles tendinopathy? If it's non-insertional, don't worry, put the patient in air cast boot, give the patient something to raise the heel, so relax the Achilles tendon, and get the patient to do eccentric training or eccentric stretch exercises by physio, and they normally respond very well. With the insertional Achilles tendinopathy, the patient may have some shockwave therapy, and this is when we intervene with surgical options. Surgical options are prone to give a good results with insertional rather than non-insertional. Non-insertional means the tendinopathy or the pathology is in the mid-substance of the tendon, and this is very difficult to treat, and the results of this is not the greatest. But insertional means it's an entheopathy, so this is a problem at the insertion of the tendon, which is easy to treat surgically. What we do surgically, we go debride the tendon. If this debridement just a minimal area, we can do this arthroscopically, we can do this open. And if we find the haglund, we can remove the haglund, we can remove the retrocalcaneal bursa or bursitis. If it's a big area of debridement, we can de-insert the tendon and reinsert it using what we call the speed bridge. Speed bridge is a special device from Arthrex, which allow us to put 4 limbs in an 8 configuration, which by 4 anchors, which hold the tendon very strongly back to the calcaneum. Because if you do a proper debridement of haglund, a proper debridement of the tendon, you will end by the tendon completely detached, and you need a strong device to hold it back to the calcaneum. This is the speed bridge. If the problem is non-insertional, as I told you, surgery is not the greatest, because you have to go and do a percutaneous tenotomy or debridement, and your debridement will end by a big gap, and this big gap in the mid-substance, the only option you have is to get the FHL to do the job for it. So Achilles tendon rupture, you are not undergraduate anymore, so you need to ignore the Simon's test. You have now what's called Simon's triad. So to diagnose an Achilles tendon rupture is not the Simon's or Thompson test, it's the Simon's triad. And Simon's triad means you feel a palpable gap, the resting position of the foot is not in plantar flexion compared to the other side, and you have a positive test, which means when you squeeze the cuff, the foot doesn't plantar flex. So to diagnose, if you ask in the exam about Achilles tendon rupture, don't say Thompson positive. No, you have to mention Simon's triad. This is the new term. And Simon's triad is a palpable gap at the Achilles rupture site, is abnormal resting position of the foot, so your foot will be resting in more dorsiflexion than the other side. And the third test, when you squeeze or when you squeeze the cuff, then the foot will not plantar flex. Again, in the exam, if you have a intermediate case of Achilles rupture or a viva, you need to remember that the risk factors, you have to ask about the steroids, you have to ask about the quinolones, you have to ask about the weekend warriors, which is the people who are keen on doing an extra extraneous activities over the weekend. So if the patient is lax all the week in doing whatever he's doing with no exercise, and come to the weekend doing very strenuous exercise and very strong exertion, this is at high risk of rupture in the Achilles. Number 2, patient on long-term steroids. Number 3, patient on recent course of quinolones, because all 3 of them get the tendon weaker and prone to rupture. Rupture will happen again at the same area where the rotation happened, 2 to 6 centimeters from the insertion. And our treatment for this, concentrate with me because I have a lot of questions about this. Our treatment for this, your Achilles will heal in either situation, non-operative or operative. And you have to be very clear with your patient. Achilles will heal with non-operative or operative. The problem is the quality of the healing and time to healing. So with non-operative measures, healing will happen. Yes, it will happen. whatever the gap is. Yes, whatever the gap is. The problem is with the gap more than a centimeter. This will elongate the tendon, and this will end by the muscle very weak, and the healing itself weaker, and it takes more time. So the patient will be in risk of re-rupture. Again, to be clear to your patient, tendon will heal with operative or non-operative measures. With non-operative measures, the healing, especially if the gap is big, the healing will be weaker, the healing will be taking longer, the healing will end by the tendon elongated because all the gap has filled with fibrous tissue. So the tendon elongates, so the muscle is weak. There's a function, will be a functional deficit. And at the end, because of all of this, the risk of re-rupture with non-operative treatment is higher. On the other side, the surgical treatment carries a risk of nerve injury, especially the sural nerve, and a risk of wound problems because, as we agreed before, skin in this area is getting blood supply from perforators from the tendon. And when you dissect the tendon from the skin, you divide the skin from its blood supply, and the risk of wound problems is very, very high. When you decide that you will treat this patient non-operatively, you have a lot of protocols: Northampton protocol, Copenhagen protocol, but the commonest and the most commonly used in the NHS is the SMART protocol, which is Swansea-Morriston Achilles rupture treatment, and this is published about 2008. It's very, very common protocol nowadays, used everywhere. On the left side, this is a protocol. When you see the patient in the emergency department, patient has to go in an equinus back slab, non-weight bearing with VTE prophylaxis. He has to be seen in the fracture clinic within 3 days. When he is seen in the fracture clinic, this is where the debate. Some people advise ultrasound for every patient, and some people use their clinical sense to fill the gap. I use the clinical sense based on how my boss taught me. So just fill the gap. If the gap to me less than a centimeter, this patient can go on non-operative treatment. If more than a centimeter, this patient will need an operative treatment unless the patient functional needs are high. So if the patient is athlete, if the patient is doing any job which needs tiptoeing, this patient will go straight away to surgical treatment. I will not depend on the gap size. The patient is not athlete, his patient is not that young, his patient is not doing any function which is dependent on tiptoeing, I will clinically see the patient within 3 days, have a look on the gap. If the gap I feel clinically is less than a centimeter, I will straight away put this patient to the vacuum protocol, which I will explain you in a minute. If more than a centimeter, this is the time I will ask for ultrasound. So if the patient is generally okay, well and fit, less than 55 centimeter, complete rupture, and the gap is more than a centimeter, the SMART protocol says operative. If not, conservative. Conservative will be the vacuum protocol and accelerated rehabilitation. My own way, as I explained you, is still the SMART protocol, but in a different way. I use my clinical before I need an ultrasound, just to shorten the time the patient will have a decision. So the vacuum protocol, you see it on the right side. This is my own practice. Oh, sorry. So basically, patient in the first 2 weeks is in plaster. He go for VTE prophylaxis for the first 6 weeks in total. Then at 2 weeks, he's non-weight bearing, anticoagulation going on. Then from 2 weeks onward, he is in a vacuum boot, and this boot has wedges in the back. It starts with 30-degree plantar flexion, and patient start to weight bear as normal. And then I book him to physiotherapy to see him at 6 weeks from the injury time. Then patient start the plaster technician or the physiotherapy or whoever in your hospital or the Achilles tendon podiatrist teach the patient how to reduce the angle of plantar flexion. So the patient reduce the angle 5 degrees, and normally 5 degrees every 5 days. So get it from 30 to 25, 5 days, then or a week, 25 to 20, 20 to 25 to 20, 20 to 15, 15 to 10, 10 to 5. Then patient at 6 weeks should be in a 0 degree on neutral dorsiflexion, weight bearing on his foot, starting physiotherapy to do eccentric stretch exercises, and carry on that. You need to remember your patient that the risk of re-rupture is the highest after 10 weeks. So from 10 to 21 weeks, this is the time where the re-rupture will happen. That's why the patient needs to be in a boot in this time, carrying on his normal daily activities with cautious. If you decide for operative, so this is the protocol for non-operative. If you decide for operative, your incision has to be just posteromedial, avoid to have a direct posterior incision over the Achilles because risk of wound problems is very, very high. Go posteromedial. Be careful about the shoulder nerve. Remember that the shoulder nerve is going from posterolateral and it crosses the midline about 10 centimeters above the calcaneum. Then it goes about 2 centimeters lateral to the calcaneum at the lower, at the insertion of the Achilles. Remember that the main strengths of your repair depend on the core sutures. The more core sutures you take, the more stronger is your repair. So 70% of your repair depend on how many core sutures you have. So either you're using a Kistler or Krakow or whatever you have, you need to use non-absorbable suture, and it needs to be very, very strong. Then you go baratino repair, and this gives you the remaining 30% of strength. So to get your repair strong, you need to increase the number of core suture. You need to repair your baratino. Core sutures number more than 4 give you 70% strong strength, and baratino repair give you 30% strength. You have 100% strength. Will you weight bear the patient or late weight bearing? The evidence says no difference between early and late weight bearing. Our current common practice is to start using percutaneous repair. Very simple, very easy. If you trained on it in a wet lab or a CAD lab, you will have it. You will do it very easily. We use now the bars system from Arthrex, and it's very easy to do. What the meta-analysis, what the evidence says, the meta-analysis says that operative versus non-operative, as I explained you from the start, operative will have a less risk of re-rupture because of proper coaptation of the ends of the tendon. Risk of re-rupture is 3% compared to 13% in non-operative. On the other side, the risk of infection is about 4%, and risk of disturbing the skin sensitivity and the wound problem is higher with the operative treatment. Functional bracing and accelerated rehab protocol has an equivalent result to the surgery without complication based on you choose the right patient. So patient not that active, not doing any push-off activity like tennis or football or whatever. Patient is not formally athlete. Other than this, we have done a retrospective review recently about our patient, and we found that the accelerated rehab using the vacuum protocol have a comparable result to the surgery except in athletes. So all the athletes were doing bad. They are not back to normal activity or function because of the weakness of the muscle. Remember, I'm doing at the moment a very big review article with a systematic review and a retrospective review about Achilles tendon. And in the next 2 to 3 months, I will come out with a full review article with an algorithm how to treat the Achilles tendon for the people who sent to ask me about where to read the Achilles tendon rupture treatment from. Give me 2 to 3 months and I will come to you with a very good evidence-based approach to how to treat your Achilles tendon ruptures. If the rupture is chronic, so primary repair is become very, very, very low chance to happen. If the gap is after you go and debride the edges of the tendon, refresh the end of the tendon. If the gap is less than 3 centimeters, you still have an option to stretch the tendon and directly repair. If more than 3 centimeters, 3 to 5 centimeters, you have the option to do a VY or a turn down flap. If more than 5 centimeters, you definitely need to do an FHL transfer. The VY advancement, you need to understand that the apex of the V is up, not down, as you can see on this right side. So you do a V up, you pull the tendon, just the superficial part of the tendon. This will end by a Y rather than a V, and you close it. FHL graft or it's not a graft. If FHL transfer, I'm sorry, this is miswritten. FHL transfer, if more than 5 centimeters, and what you do, you get the FHL from as distal as you can around the knot of Henry and pull it up, make a tunnel in the calcaneum, insert the FHL, and then repair the Achilles over it. So the FHL is not only doing the job of the Achilles, but the FHL will be making a good vascular bed for the Achilles, the chronic Achilles rupture to heal. Tip and rupture, remember, tip and doesn't lacerate. Doesn't lacerate. Tip and always degenerate. AHL lacerate, but tip and degenerate. So when you have a tip and rupture, it's very, very uncommon to be traumatic rupture. It's mostly a degeneration rupture. So the problem is pathology of the tendon, not the trauma. Yeah, there is a precipitating trauma, but not traumatic. Common is to have a traumatic rupture of EHL. But tip and is commonly to have a pathological rupture, not a traumatic rupture. Anatomy, you know more than me. How the tip ant appear. This is the normal tension of the tendon if you see in the picture. Commonly, this happen in the middle-aged people, and as I told you, is minimal trauma, eccentric loading on a degenerated tip ant. It's very, very uncommon to see the tip ant lacerated unless direct injury, cut it with a knife. It's very uncommon for the tip ant is very, very thick, strong tendon. So it's very, very rare to be traumatically lacerated unless direct injury. It's common to be degenerated and a minor trauma precipitated the rupture. The classic triad, you will find that rather than this clear tendon, you'll have a pseudo tumor here, just some swelling here. This contour of the tendon will be lost, and the patient will be having a weak dorsiflexion. And for dorsiflexion to happen, the patient will recruit the extensor tendons of the toes. That's why you will find the toes in hyperextension. How to treat it? Acutely within the first 6 weeks, all what you do is go and directly repair it. And you need to do a proper repairing with a proper core suturing. If it's a chronic rupture, the option is to reconstruct. And the problem of reconstruction is difficult to find a muscle which is doing the same action and in the same line of pull. But the options we have either the EHL or the plantaris. FHL pathology as the last one. So commonly the FHL pathology is the problem you will see with osteogonum. With osteogonum, there's a prominence of the posterior between the medial and lateral tubercle of the posterior tubercle of the talus, and that is where the FHL groove is. So it's always impinging there, and the rupture happened at this site. FHL come from the back, very fleshy till the end, then go posterior to the talus in the groove between medial and lateral tubercles, then go underneath the medial malleolus, then at the knot of Henry in the plantar side of the foot goes dorsal to the FDL. Patient will be at this side of knot of Henry. There is a lot of cross connection between FDL and FHL. That's why if you harvest the FDL or FHL proximal to the knot of Henry, the same function will be maintained because one tendon can do the job of two. Definitely not by the same power, but at least the patient will have the function. So when you harvest the FHL or FDL, you need to be sure that this happens before knot of Henry to maintain these cross connections, getting the two tendons to act. Commonest cause of the problem of FHL is the osteogonum, and this is commonly happen with the people who put the ankle in a lot of plantar flexion, like the gymnasts, the dancers, especially, and the athletes. What the patient will complain if there is an FHL pathology or FHL tenosynovitis, the patient will have clicking and locking when he moves the great toe. Triggering, clicking, and locking when you move the great toe. You diagnose it easily by MRI scan. It will show you the tenosynovitis and the tendon signal inside the tendon. And the treatment, firstly, to release that by an arch support. And if there is no option, is go and release the FHL from the posterior, from the fiber osseous tunnel in the back. Thank you so much. And sorry, but a bit long, I know. So we're nearly done. So all what we need, all what we will do next time is we still have the accessory and then accessory bones, and then we'll go for trauma. And trauma will be more interesting than the pathology, but it's very, very important for you to know that. Foot and ankle is very, very enjoyable, but the people who doesn't normally do foot and ankle, they feel that it's very, very simple. It's a lot of mechanics. Remember, there is 28 bones in the foot, a lot of joints, and you need to understand the mechanics very well to deal with the foot and ankle problems. Next lecture, maximum 2 lectures we've done with this project, with this course. Next time we'll have the accessory bones and the trauma, maybe one or maximum one long lecture and one short lecture, or 2 short lectures over the next 2 Fridays, and we're done with this, and then we can think about another topic to go through and make a course about. 7 questions. Are they all done?
No questions. No,
does MRI scan, Rafat is asking, does MRI scan has a rule? Yes, it has a rule, but the point is we don't do MRI scan except if it's a chronic rupture. With acute rupture, no. With chronic rupture of Achilles, we do an MRI scan, firstly to show us properly the tendon and the situation of the tendon, and we need to check the FHL as well, because with a chronic rupture, there is a good chance we do an FHL transfer, and we need to be sure that the FHL transfer, that FHL is okay to do a transfer on. So MRI scan has a rule only if there is a chronic rupture of Achilles or pathological rupture of Achilles. Acute traumatic rupture, MRI has no rule. Okay? Any more questions, guys? Okay, good. If this all, so this all from me, and again, recording will be available on mid-all for all registered, and you'll receive a feedback from mid-all. Please put your feedback. This is very, very important for me to improve it session after session. Feel free to say whatever you feel, what's good, what's bad. All your comments are appreciated, will be taken on board. And you will receive a certificate once mid-all approve it. I'm still waiting. I've got primary approval for the credit hours, and I'm waiting for the Royal College to confirm the credit hours accreditation for this course. The point, that we have a holiday season, so everything is delayed in the UK. But yeah, soon I will have the accreditation for this course, and all your certificates will be having a credit hours, a credit points in it. Again, thank you so much for attendance, and thank you so much for staying for more than 1.5 hours. Sorry for the long lecture, and we are nearly there. Good luck with your exams, and have a good evening. And yeah, if nothing, that's okay. Hassan, any comments?
Thank you. No, thank you, Sir Hashim. Thank you so much.
Have a good evening, and see you next Friday. Bye.
Thank you. Bye bye.